Well, let's head to our discussion now. 32 states and the Federal Capital Territory have reported suspected cholera cases in 2021, according to the latest cholera situation report by the Nigeria Center for Disease Control. Now, the report indicated that the country has so far recorded a total of 100,057 suspected cases, including 3,449 deaths from the 32 states and the Federal Capital Territory in 2021. The ncdc noted that of the suspected cases since the beginning of the year, the age group 5 to 14 years is the most affected for males and females. The outbreak status shows that cholera is still active in Bauchi, Zamfara, Sokoto, Kebbi, Borno, Yobe, Niger, Kaduna, Gombe, Adamawa, Benue, Oyo, Kwara, Ogun, Abia, and Cross River states. With me in the studio for more on this is a public health specialist, Dr. Nsabasi Ekanem. Good morning. Thank you for joining us.
Thank you for having me.
Now, this matter is said to be, or this outbreak is said to be the worst in Nigeria's history, and we've been battling cholera for years. How did we get to this level where it has become so bad?
Well, I think that in Nigeria, despite the global strategy or global roadmap for eliminating cholera, which Nigeria has actually demonstrated, in 2017, we took an extra step of developing oral vaccine against cholera. I mean, we rolled it out in September 2017. Unfortunately, consistently, we have always been reactive rather than proactive in all of this. So you get to see cholera outbreaks happening in different states. And instead of us to probably be rolling out immunizations or vaccination against cholera in this state, particularly at the period of time where cholera is often reported, we actually wait until cases are reported before we start implementing actions. And because of this rather reactive, strategy, most times we have already some burden, some cases, and then of course case fatality before we begin to react to it. And that's why we keep seeing cases almost every year. Almost every year, Nigeria has record cases of cholera. And if you notice, this happens in a particular time of the year. So the question is, why not be proactive? We know the particular part of the season or the time in the year where we have cases of cholera. So why don't we probably roll out these measures early enough so that we can nip it at the bud? Now that we have oral, vaccine against cholera, I think it's important that we think of being proactive by rolling out these vaccines, particularly in those hotspots. I mean, like we listed, there are some states in the northeast, in the northwest, and even in the north central that are prone to cholera. We need to be more proactive. You see, global burden reports on cholera has shown that sub-Saharan Africa, is actually the hotspot when it comes to cholera. I think in 2017, out of about the global cases, just 17 countries in Africa contributed over 150,000 cases of cholera. So it is already a no-brainer that, yes, cholera is endemic in Africa, particularly in sub-Saharan Africa.
Why is that?
Well, it's because of a lot of factors. One of it is the constant cases of open defecation. It is one of the factors that promotes the spread of cholera. Up until today, you find out that in many sub-Saharan African countries, open defecation is still seen everywhere. And you see, what happens is that when people defecate on the surface of the earth, and then probably due to rainfall, there's flooding, so the running water carries this fecal matter into water bodies, surface water, wells, and other sources of water that people get their drinking water. Unfortunately, also in sub-Saharan African countries, including Nigeria, there is absence of potable water, sufficient potable water. Up until now, 80% of Nigerians still, having to get their own source of water. Then 80% of Nigerians don't have access to potable, pipe-borne water. And because of that, you see, people are more exposed, particularly in the urban, the rural areas and the suburban areas. People are still exposed to waterborne diseases like cholera, foodborne diseases like cholera. So these are some of the factors that is making us more prone to cholera. Now that we know, what is important for us is to roll out strategies. All right, we have the entire roadmap, the global roadmap for the elimination of cholera by 2030, and in that charter we have a number of programs that we can roll, a number of policies that we can actually enforce, to reduce the burden and the mortality of cholera. I think what is important for us is to actually put these things into action so that we won't be seeing cases like this. I can assure you that as it is now, next year, 2022, we'll still have
record another case.
Cases, so we need to actually act proactively so that we can reduce the scourge of cholera.
Proactively, that's the word. Now, you mentioned something while you were talking about the causes of cholera. You talked about food. And I'm wondering, how does it affect food? How do people, contract this virus from food?
Well, basically, cholera, as it were, is a diarrhea, an acute watery diarrheal disease that is caused by contaminated food and water. All right,
contaminated.
So the thing here is that when food that we take in, is contaminated with the pathogen. The pathogen is known as Vibrio cholerae. All right, not all strain, though. There's specific strain of Vibrio cholerae that actually causes cholera. Now, so when food, the ingested food is contaminated with that pathogen, the person who ingests it is likely going to come down with acute watery diarrhea. But of course, it's for people older than the age of 2 years. All right, so now, the thing is, a lot of Nigerians don't pay particular attention to the hygienic level of the food they eat.
Right? They just want to eat.
Some people just eat. I mean, you move around Lagos. Sometimes I move around in the course of my work. I'm a public health consultant, so part of my work is to do some level of observation, surveillance by observation. You see people eating just close to the latrine. You see people preparing their food just close to where refuse is being dumped here in Lagos. So we see things like this.
So the virus jumps into the food, or what?
The thing is, sometimes they use the same material that they used, probably the turning stick. They drop it on the floor. They drop it on. So this thing
hygiene
picks up. Yes. So what about hand washing? If not for COVID-19, I tell you that Nigerians were not in the habit of hand washing at all. The first time we actually had was in 1961 when we had the great pandemic in Nigeria.
Yeah. And
then later on was Ebola.
Yes.
All right, that we started washing our hands. Lassa fever also. Then the grand one was the COVID-19 pandemic. So Nigerians actually don't have that attitude, don't cultivate that attitude of washing hands. And I'm sure that I'm happy. Sometimes I look at the COVID-19 pandemic as having a win-win kind of thing, because it also gave us that awareness, reawaken our consciousness about hand hygiene and environmental sanitation. So when it comes to cholera, two things: personal hygiene and environmental sanitation is very key.
Absolutely.
So when we are in areas where probably the environment is not at a good sanitary level, we are likely going to contact this, because any form of transmission whatsoever of these Vibrio cholerae would cause cholera.
Now let's look at the age bracket here that is said to be most susceptible to what is going on now, 5 to 14 years. Why is that? Okay, well, 5 to 14 years is between the age of late childhood, to puberty or early adolescent ages. And this age is one of the most active ages of people. Okay.
At the age of 5, a child wants to do anything, wants to explore. Of course, as an adolescent, there's this. So you see, this activity, this active age, exposes them to do so many things, and sometimes at this age too, they don't actually pay particular attention to certain things, including the food and the source of
hygiene.
water. Basically the hygienic level of what they take in. So that's why we are seeing this cholera among this age. And this age is also to an extent an age of mobility, where they move from one place to the other. So they're likely going to pick up food somewhere, water somewhere, and all of that. So, but what this points out to is the fact that if we are developing programs against cholera, we should actually target this set of people.
Right.
Now, for example, the oral vaccination against cholera, if we are rolling out this program, millions of doses I'm sure has been administered since 2017 September. We should be targeting this population because it shows us that they are more at risk based on the current situation.
Do we even have those who are gathering data as we speak with regards to all of this development? Like you mentioned earlier, year in, year out, we know already that at a particular time we face this outbreak.
Well, I would say that the NCDC is trying. I must tell you, I was part of the last project NCDC did in terms of antimicrobial resistance and all of that. And I'll tell you that NCDC is trying with partner organization from Fleming Fund and all of that to see how they can collect data, have a reservoir or a database of some of this essential data that we need. And I would want to say, yes, one of the problems we have in Africa, not just in Nigeria, is paucity of data, because there are not programs that there are not enough programs that actually seek to collect data. But then I want us to probably, what we should be doing is that probably we should use this as, or the COVID-19 pandemic plus this as a wake-up call to say, look, let us start investing in collecting data, so that if we identify a certain class or a certain group of people, age group of people that are susceptible to a particular disease, we can develop programs that targets that particular group. So it's about data collection. I think we are beginning to see the need, and I think that we are making efforts in that regard.
It will help direct, channel our energy appropriately
to the people
addressing
who need
this matter.
Exactly.
So now you spoke about vaccine, and one thing a lot of us believe is that vaccines are meant to address challenges and bring it, whatever it is, talk about COVID-19, to see how we can minimize the spread and all of it. You've been talking about administering vaccine for cholera since 2017, yet we are still seeing these things reoccur. What's the issue?
Okay, well, like I said, unfortunately, while we have the vaccine, most of our programs are reactive. We only administer vaccine when it has happened.
Once someone takes the vaccine, isn't it supposed to protect the person from being able to contract the cholera virus?
Yes, so what the vaccine does is to reduce the risk. Like I said, vaccines do not eliminate the risk 100%. No vaccine on earth eliminates the risk of contracting a particular disease 100%.
Right.
So there's a level of what we call the efficacy level of vaccine. It shows that how much of protection do you get from the vaccine. All right. So you see cases, we hear 94%, 95%, and all of that. When you hear cases, efficacy of 94% or 95%, it means that out of every 100 person, about 94 will be protected against the virus. But what is important is that vaccines is what we call pre-exposure prophylaxis. Vaccines are supposed to be administered when people are not yet infected with a particular disease.
Right.
So for us to be able to actually eliminate cholera in Nigeria, we must learn to administer this vaccine even before we start seeing cases. I mean, from the cases we've had since 1991, I'm very sure that we have a fair idea of the particular time in the year when cholera cases are reported. So it's important that we first of all identify that time in the year and identify the hotspot. I'm sure by now we have those numbers, we have those data.
Do we have the vaccines available?
We have the vaccine. We have
readily available that can be cut
vaccine
across the 36 states of the federation?
Well, I can't say about the 36 states, but right. I'm saying that the Nigerian Primary Healthcare Development Agency can have access to the vaccine actually. All right, like I said, that between September 2017 till today, we have administered millions of doses have been administered already. But what I'm saying in essence is this: we only administer it when cases have happened. For example, if we hear that there's an outbreak in Enugu, we'll start moving there. When we are doing Enugu,
another state.
The neighboring state, we are not even considering.
Right.
And you know that these things move as fast as like wildfire. So it's important for us to, the moment we hear, even when we learn about a particular case in a particular state, we should use that as we should initiate a mass vaccination campaign to say, look, yes, cholera is here. That means we need to have people vaccinated against cholera. So it's something that we should be proactive and not reactive. We have always, and I put it very clear, that from all the cases year in, year out since 2017, we have always been reactive. It is only when it has happened that we start rolling out vaccines. But it's supposed not to be so.
So who is supposed to lead the approach towards changing how we've been addressing these matters? The government or primary healthcare? Who are those? Well,
basically, it's under the purview of the National Primary Healthcare Development Agency, to administer vaccines. So, yes, the Primary Healthcare Development Agency is saddled with the responsibility of making sure that they help to control the spread of diseases. Let me put it in collaboration with the NCDC. All right, so NCDC rolls out the strategy, but National Primary Healthcare Development helps them to bring it down, cascade it down to the.
So the NCDC level. Is saddled with that responsibility.
Yes.
So it should know, since it's the one collecting data and trying to collect data, that approach needs to change as we speak. Yes.
I believe there was a report. There was a study that was carried out in 2018. I think one of the persons one of the author was the former Director General of NCDC, Chikwe Ihegwaso. So in that particular paper, I went through that particular paper some time ago, and I saw that the modalities was rolled out, on how we can address. And one of the things that the paper considered was that we need to be proactive, just like I said, and that we need to make sure that there's a multi-sectoral, approach to this. Because when you look at cholera is not just a health. The social determinants of cholera is not just health.
Right.
We have Ministry of Water Resources must make sure that we have access to potable water. All right, we need Ministry of Housing. We should make sure that people have affordable and comfortable housing to stay. We have Ministry of lands, so the Ministry of Environment should also look at
multi-sectoral collaboration. Yes. So if the NCDC knows that it is how they are approaching this, sectors as well as ministries, and ensuring that they have collaboration, communication, not just having a paper, but also pushing to see that they have, dialogue to addressing that.
Put these people together, let them draw up a strategy, all right, that will be implemented with the target or with the goal of eliminating cholera in Nigeria. I think it's something that is actually doable.
So 2030, is it achievable?
2030, we are looking at eliminating cholera from 20 out of the 47 countries. It's possible, but then the question is, what actions are we putting in place to achieve that goal?
With our actions that, as we speak, is it possible?
Well, I would say that with the action currently, with the current trend, is not possible. But if we, and I believe that we are going to change the narrative now, because
hopefully
what we've learned now, and I think with that we should be able to achieve elimination by the year 2030.
All right, we leave the conversation here now. Dr. Nsabasi, public health specialist, thank you so much for your time.
Thank you for having me.
All right.